So, dear colleagues, good morning and welcome. I'm Rosemary Forstner. I'm a radiologist from here in Salzburg. It's a privilege to be here again at this podium in this course. And in the next 45 minutes, I will make you familiar with gynecological emergencies. I will also show you some aspects during pregnancy, and here I will focus on non-obstetric causes of gynecological emergencies. But let me start with some clinical background. Actually, the majority of gynecological emergencies can be diagnosed by the combination of clinical history, laboratory data, gynecological assessment, and transvaginal sonography. However, sometimes it may be difficult, and the reason is that there is an overlap with gastrointestinal pathologies and the wide range of differential diagnosis. Gynecological emergencies warrant immediate treatment, but some of these may be life-threatening. And these include rupture of extrauterine pregnancy, of ovarian cysts or abscesses, and uterine rupture. And non-obstetric emergencies during pregnancy are rare, but they are very difficult because of the overlap of symptoms of pregnancy and the potential loss of the baby and the mother. So I will start with a case. It's a 19-year-old who had a sonography, and sonography shows a large mass. It's solid, it's cystic. She has acute pelvic pain. And the value of sonography is that it helps to guide management. Is this a true emergency that warrants immediate surgery? Is this a self-limited process where follow-up may be found? It's not in this case. Or is further radiological imaging warranted? I will come back to this lady in a couple of minutes. But it's indeed sonography that is the first-line imaging modality when it comes to diagnosing patients with acute pelvic pain in fertile age. And then the clinical diagnosis obtained on the basis of sonography then guides further imaging. And if the suspected diagnosis is gynecological, then MRI is preferred over CT. However, in the acute setting, sometimes CT may have to be performed. If the reason, and that's really important, also in fertile age, is assumed to be gastrointestinal, urological, or vascular, then it's CT that is the modality of choice. And of course, in children and in pregnancy, MRI should be performed. So sonography is the most important imaging modality. It should be combined transvaginally with the duplex technique and also combined it with transabdominal sonography. It's easily accessible, but unfortunately in Germany and also in Austria, transvaginal sonography is not done by radiologists but by gynecologists. So CT and MRI is what we as radiologists can offer in this clinical setting. CT is classically performed in a venous phase. In some instances, we may perform low-dose CT, and this is particularly the treatment, the diagnosis of choice when it comes to urolithiasis. And this image already shows the potential difficulty and limitation of MRI when it comes to imaging of emergencies, because in MRI, we cannot only perform one series and one sequence, but optimally we have to combine all these sequences, and this takes at least 20 to 25 minutes. And do remember that if the patient is pregnancy, you should avoid gadolinium. But MRI is the best imaging modality when it comes to characterization of gynecological masses, and this is particularly true when it comes to assessing of complications. So I have divided this lecture into two parts. I will first discuss gynecological emergencies in fertile age, and then in the second and the shorter part, I will discuss non-obstetric emergencies during pregnancy. So let me get started with the gynecological emergencies in fertile age. And this slide shows you the typical age presentation of patients presenting with gynecological emergencies. And it's typical the mid-20s to mid-30s where there is a peak. So this is fertile age. Gynecological emergencies almost never are seen in postmenopausal age. That's more due to tumors, but not the classical gynecological emergencies. And sometimes in late adolescence, there may also be, of course, gynecological emergencies. So this is a quite interesting study that showed what are the most common diagnoses of acute pelvic pain, both in pregnant and in non-pregnant ladies in some of these series. And what you can see is, number one, the range of differential diagnosis is not so big, but what you can also see that ovarian torsion, that is well known as emergency, is quite rare. Endometriosis is also, as well as ectopic pregnancy, but this is really important to diagnose because this is life-threatening. The most common causes are ovarian cysts and pelvic inflammatory disease. But, and that's also important, in all of these series, appendicitis did play an important role in the differential diagnosis of a patient presenting with acute pelvic pain. And this was just the case I want to show you. She had sonography, and in sonography this cyst was seen. The question was, could this be an abscess or some gynecological tumor? But if you look closely, there is this lesion at the top of this cyst, and on the transaxial, we can clearly identify this as an inflamed appendix. So in this case, we had an appendicitis, and this mass was a coexisting endometrioma. This was seen during surgery. So what I want to do now is go into the differential diagnosis of various pelvic emergencies and start with an overview. And here you can divide pelvic emergencies or gynecological emergencies into three different categories. These include the true gynecological emergencies, postpartum and operative complications that I will not cover, but I will show you the most important obstetric case where we as radiologists may have to play a role, and this is uterine rupture. And here I want to share with you a case of the literature this is a CT, and we see here the hand already outside the uterus, and this is also confirmed in emergency surgery. But I want to draw your attention to the history. This lady already had 7 previous cesarean sections. So this is what you have to be in mind, because cesarean section is a risk to develop uterine rupture. This was a patient we had. She had also a history of cesarean section, and during vaginal delivery, she developed heavy pain. Sonography showed ascites. She had an acute CT. And here in the CT, we see a hematoma at the site of the previous cesarean scar, and there is clearly ascites, and the density advocates that this is a hemorrhage. She was clinically stable, so this was why she had a follow-up. And 3 weeks afterwards, we see that the hematoma has a little bit increased in size, but it's a subacute hematoma. And what you can also see is that even 1.5 years afterwards, there is a scarring remnant of this hematoma. But she did have a normal delivery afterwards. I don't, this is, now in the contrary, it's quite, yeah. Yeah, it's better, yeah. So it's better, okay. Yeah, okay. So let's continue. So what should we know about uterine rupture? It can be clinical significant, but also occult. It's the cause of fatal death. And these are the risk factors, and you should particularly remember cesarean section. And if the cesarean section scar is very thin, and this may appear or happen during pregnancy and labor, and the typical site is the site of the cesarean section. And there is a terminology, it's more of semantics, but uterine rupture is defined as full thickness tear, whereas uterine dehiscence is defined as rupture where the serosa remains intact. So now I want to discuss these different categories of gynecological emergency, and these can be divided into extrauterine pregnancy, hemorrhage, due to various cyst ruptures or tumor rupture, adnexal torsion, and the spectrum of pelvic inflammatory disease or tubo-ovarian abscess. And what I will do is I will focus on the differential diagnosis and give you some tips that help you to make the diagnosis. And we'll discuss these categories I showed you according to these clinical situations that are quite common in daily life. So I will discuss the first clinical scenario, and this is acute pelvic pain and hemorrhage and free fluid. And when we have such finding in a woman of fertile age, then all the time we have to exclude ectopic pregnancy. And there's this pregnancy test that is crucial to make this diagnosis or to exclude this. So I want to show you a case, a patient who came with the question appendicitis, or is it a gynecological disease? She had severe pain. And what we see is that there is a lot of ascites in her left lower quadrant, but also in the Morrison pouch. This is much too much for appendicitis. You never have in appendicitis so much free fluid. So the next test, of course, is the pregnancy test. This was positive, and it was extrauterine pregnancy. So that's really crucial, and you have to call your doctors immediately that she's taken to the surgery room. So another patient, 35 years, referred from surgery, pain, rule out appendicitis, and that's always the question we get from these patients. Menstruation was reported to be 2 weeks ago, and what we see is the uterus with high endometrium, and there is a cystic mass, there's a nodule, this was moving a little bit, and there is free fluid. So this is a classical finding of extrauterine pregnancy, and if you suspect this, you should perform also a duplex, and here usually you find that the rim is well vascularized, and this is the so-called ring of fire sign, but this is not specific. Again, for the diagnosis of extrauterine pregnancy, you have to have the beta HCC, and this should be elevated. So ectopic pregnancy is really a true gynecological emergency, and it's still a really important cause of maternal death. So we do not have to miss this. There is an increased risk in patients who had pelvic inflammatory disease or assisted reproduction procedures. And the classical site of extrauterine pregnancy is here, the area of the temporary part, the femoral part, adjacent to the ovaries. There are also other sites, of course, of extrauterine pregnancy. And the problem is, as all of these classical triads, they are only found in less than 1/3 of the cases, but it's really transvaginal sonography that plays the crucial role, and it helps to identify extrauterine pregnancy if the beta HCC is elevated from week 6.5, so really early pregnancy. So transvaginal sonography really plays a crucial role, and the question is the need for other imaging. I think this is a very nice paper that addressed this issue, and they found that it should only be performed in sonographically independent cases, that's one. And second, the patient has to be stable, and the information is necessary for patient management, not just to confirm it, because this is done by sonography. Do not forget that if the patient, if the pregnancy could be vital, then IV gadolinium should not be performed, and CT does not play a role when there is a suspicion of suspected pregnancy, but of course it may be found coincidentally in the diagnosis of a patient with acute abdomen. This was a case we had. She was in early pregnancy, and sonography saw a pregnancy in the cesarean scar. Here, MRI was performed to confirm this diagnosis. Obviously, the gynecologist just wanted to make sure. Why? because as this also could be performed by MRI, methotrexate therapy was initiated to finish this pregnancy. I said that CT does not play or have a role in the assessment of ectopic pregnancy, but patients just often don't know that they are pregnant, and this is why sometimes we may diagnose ectopic pregnancy in CT. So this was a patient who came to the emergency room. She had a history of pain already 2 days ago, presented with acute abdomen, hypovolemic shock. There was history of ulcerative colitis, so the question was more likely peritonitis, perforation, something like this. But if you look at the free fluid, it's quite dense. It's dense in the upper abdomen, but denser here in the pelvis, and this is this sentinel clot sign. And this enhancing little mass was the extrauterine pregnancy that had ruptures and caused a lot of hemorrhage and induced hypovolemic shock. The imaging findings of a rupture of a functional cyst may be identical to that of extrauterine pregnancy, but the pregnancy test is negative. And actually, hemorrhage into functional cysts, and these are typical corpus luteum cysts, is quite common. It's classically found at mid-cycle, and it can be very painful when the blood induces chemical peritonitis, and if the hemorrhage is severe, then it may also result in hypotension, hypovolemic shock. In the majority of cases, sonography is the modality of choice, and usually, if necessary, the gynecologist just will go to laparoscopy. But sometimes, if the patients are not in a better condition, or if there are differential diagnostic issues, then further imaging, and here MRI plays a role. In our clinical setting, these are usually children or young adolescents where they don't just want to get in for laparoscopy, and the clinical question is usually, is it appendicitis or something else, or is it an ovarian cyst? And this was a case of an ovarian cyst rupture, in a 15-year-old. Here, the appendix is normal, so appendicitis could be excluded. There was a little bit of fluid around, but MRI showed a cyst. This cyst had an hemorrhagic level. There's a little bit of fluid surrounding this, and this was the correlation in sonography that at the first sonography just was missed because of a lot of bowel air overlaying this. So, but this could be diagnosed as ovarian cyst, rupture, no appendicitis, and this was why she was only followed. So just to finish this, what are the differential diagnoses? If we have a patient with hemorrhage in fertile age, then we should think of gynecological causes, extrauterine pregnancies, ovarian cyst rupture. It's the pregnancy test that makes the difference, but also other lesions like endometrioma may rupture, ovarian cysts under hyperstimulation, and also uterine gliomas may sometimes rupture. Vascular malformation or tumors usually lead to bleeding through the vagina. Let's now move on to another clinical scenario, and this is a patient presenting with pelvic mass and acute onset of severe pain. And if we have this constellation, then we have, of course, to exclude pregnancy. But if ectopic pregnancy has been excluded, we should think of torsion. And remember that classically torsion is seen in the ovaries or fallopian tubes, but sometimes other structures like uterine fibroids or pedunculated pelvic tumors may also get torsed. And so this brings me back to the young lady I showed you in the beginning, where a large tumor was seen. It's solid, it's cystic, it's in the right paramedial lower abdomen, and here an MRI was performed. And in the MRI we see the same. We see a cystic mass, but there is another mass that is solid, and here in the periphery you see little cysts. On the transaxial, we can see that it's midline, and it's not the right ovary because this is the right ovary, this is the left ovary, and this is a classical finding of a torsed ovary. And the classical finding here is the string of pearl sign, and these are the follicles that are in the periphery of a mass that's quite bright on the T2 weighted image. So that's classical finding of a normal torsed ovary. She did undergo surgery, but unfortunately here the ovary was already completely necrotic, and the cause was these hydrosaplings that served as a hypomochleon. So what should we know about adnexal torsion? Actually, adnexal torsion is a quite rare but well-known emergency. It's classically found in premenopausal age. And remember, there is an increased risk of ovarian torsion in patients who are pregnant, and it's particularly in the first and second trimester. What are risk factors? Usually these are cystic benign masses, and the size plays a role. Usually the size is larger than 5 centimeters, so large cystic benign tumors. And in children, also normal ovaries may undergo torsion. And there are 2 clinical settings. One is the acute with really severe pain, nausea, sudden onset. And there is also another that is a more chronic with torsion and retorsion. And sonography is the modality of choice to assess adnexal torsion, and the role of CT and MRI is that as an alternative modality in indeterminate cases. And this was a case of a 45-year-old with severe pain, large palpable mass. Here you see the sonography, it's really quite large. It was in the mid-abdomen, and here a CT was performed just because it was not, the torsion was not even suspected. And what we see here are really, in this case, the classical signs of adnexal torsion. This is why I want to share this with you. So what we see is a large mass. It's here has fatty contents, so we can diagnose this as a dermoid cyst. It's midline. This is also typical. It's quite atypically high. There is only minimal ascites that's in here. And another feature that's typical and pathognomonic of torsion is the dilatation of the vessels that are at the base. If you scroll these images, you might see a whirlpool sign. So that's all the classical finding of torsion. Do not forget that pedunculated other structures may undergo torsion, and typical for this is the cause of pedunculated fibroids. They may torse, and in this case, this was a case of a necrotic fibroid that had undergone torsion, and in this case, it had mimicked cervical cancer, but it was nothing else than torsion. And typical for torsed fibroids is that they degenerate during this process of torsion. This is why they have a high signal. Another feature produced by fibroids and causing pain is hemorrhage. This may be found in women who are under hormone treatment, but also in pregnancy. And this was a lady in her early pregnancy. We see the pregnancy, and there are 2 subserous fibroids. Here on the T2, we cannot explain why these are probably painful, but if we look at the T1 weighted image, there is clearly hemorrhage. Why? Because in the T1 weighted image, there's a bright signal. If you perform T1 fat set, it would stay bright, so it's a classical finding of hemorrhage. That's quite often a cause of pain in pregnancy. So let me go to the third clinical scenario, and that is pain and septic context with or without the mass in the pelvis. And if we have this clinical constellation, of course, appendicitis and pyelonephritis should be ruled out. But if this has been ruled out, then pelvic inflammatory disease is the most probably diagnosis. And it's a quite common cause for women to come to the emergency rooms. And if we have a bilateral cystic mass in this clinical context, we should think of tubo-ovarian abscess. And if the patient has a long history of intrauterine device, then we should think of a subtype of tubo-ovarian abscess. That's tubo-ovarian abscess in actinomycosis. Sonography often is not really diagnostic, and this was such a case. 45 years old, CRP is quite high. In sonography, we see a mass. This is consistent with an abscess, but the question is this abscess tubo-ovarian abscess, or is this an abscess due to diverticulitis? And this is where sonography is limited, and this is where further imaging is helpful, and the next imaging technique, at least at our institution, we would do a CT. And this was also done here, and we see the uterus, and there is a left cystic mass. On the coronal, we can nicely appreciate that this is a tubular mass, but there is also signs of peritonitis here, also this peritoneal thickening, and here this fatty infiltration. So what we see, this mass here is the dilated fallopian tube, and the presence of this dilated fallopian tube in the setting of an inflammatory mass allows the diagnosis of tubo-ovarian abscess. And in this case, it was a tubo-ovarian abscess with secondary sigmoid involvement, and this was the finding at surgery. So remember that tubo-ovarian abscess and pyrosalpinx is the hallmark for pelvic inflammatory disease, and for abscess, that it's a severe form of pelvic inflammatory disease. And actually, pelvic inflammatory disease is an umbrella term that summarizes all inflammatory disease of the upper genital tract involving the uterus and the adnexa. It's classical for fertile age and really common. These are the classical clinical features, and remember that only in 1/3 of the cases the symptoms may be atypical, and this is again where sonography is not enough, or clinical examination is not enough, and where CT or MRI play a role complementary to sonography. Yeah, and tubo-ovarian abscess is what we can really good diagnose either with CT or with MRI, and it's like the late stage of pelvic inflammatory disease. And what we should look for multicystic, typically bilateral adnexal masses. The pyrosalpinx is the hallmark, so look if you can somehow identify a tubular cystic structure within this. And the second thing you look for are signs of peritonitis. Here we see in the center the pyrosalpinx, and here signs of peritonitis. The same, the pyrosalpinx seen on MRI and also on the T2, and here with contrast enhanced medium in MRI, you can better appreciate this inflammatory type of enhancement and also the pelvic peritonitis. So an interesting syndrome is the Fitzhugh-Curtis syndrome. Why? Because actually these are patients who have PID, often tubo-ovarian abscess, but actually clinically they also present with upper abdominal pain. And the reason is perihepatitis associated with pelvic inflammatory disease, and if you perform according to the literature an arterial type of sequence or CT, then you should see an enhancement of the liver capsule and of the peritonitis. This was a case we had. Clearly, this is tubo-ovarian abscess showing the pyrosalpinx, but there is also a lot of inflammation surrounding the liver, and she presented with upper abdominal pain. So, is there a role for MRI? In my opinion, it's much more difficult to diagnose MRI, the tubo-ovarian abscess with MRI, but it is a problem solver. Usually when CT is inconclusive, sonography also is inconclusive, and this was such a case. This mass was seen in sonography. CT in this case was inconclusive, and it was not clear, is this endometriosis? Could this be tubo-ovarian abscess? Probably not likely diverticulitis. But what we can see here, this is T1 and this is T2. And the question of endometriosis can be ruled out because there is no high T1 signal, so this can be ruled out. Now, let us think, could this be abscess? And here, if we look at the T1, there is clear an enhancing mass, and there is some cystic elements, and this look like a tubular structure. And now comes the strength of MRI, and this is that we can show pus. And pus is where these fluidy structures here have a diffusion restriction. So this indeed was tubo-ovarian abscess. This was tubo-ovarian abscess. Here we see some elements of the ovary, but this was the dilated, inflammatory, changed Pio-Selpings. So it was Pio-Selpings, and here the value of MRI was to ascertain this due to the diffusion-weighted imaging. So let me finish this differential diagnosis. If we have a patient presenting with pain, mass, and signs of inflammation or pelvic, we should think of tubo-ovarian abscess. But of course, we have also to exclude abscesses of other etiologies, particularly in diverticulitis or appendicitis. And sometimes, but this is rare, rupture of endometrium or of dermoids may cause pelvic chemical peritonitis. So if we have such a history, this should be included in the differential diagnosis, and imaging helps to make a difference. So in the last 10 minutes or so, I will now cover non-obstetric emergencies during pregnancy. And actually, this is really a challenge. Why? Because both in diagnosis and therapy, because these will affect not only the mother, but also the baby. It requires prompt treatment and also needs a multidisciplinary team approach. It may also be difficult because some of the symptoms of acute abdomen may be the same as the symptoms caused by pregnancy. And remember that the causes of acute abdomen in pregnant women are the same as in non-pregnant women. So there is no difference. Approximately 2% of pregnancies will, with patients with acute abdomen, will require surgery. And here imaging really plays an important role because we know that the delay in diagnosis is the single most important factor affecting the morbidity and the mortality, and also to prevent loss of the baby. When it comes to imaging, of course, sonography is the first-line imaging modality. If further imaging is necessary, and it's quite commonly, and I will show you why, MRI is the second-line imaging modality, but, and that's an important message, if there is indication, you can also perform CT. Of course, you have to speak with the patient, but here I have from this literature radiation doses for different CT modalities and X-ray modalities. And if you look at the literature, the critical maternal dose of more than 50 milligray is usually not reached, and particularly it will not be reached because if you know the patient is pregnant, you will reduce your dosages in CT as much as is possible, and so this ALARA, as low as reasonably be achievable motto is true for radiation exposure. This you will do. But this ALARA principle is also true for MRI. So if you have a patient who is pregnant and you do an MRI study, you will also try to image as short, as rapid as possible. And this is the protocol as suggested by the European Society of Uroradiology. What they suggest is either perform fast T2 with balanced gradient echo sequences in an axial or coronal or sagittal, or fast T2 like CAST, again axial or coronal and sagittal. Combine it with a T1. Now we would probably perform Dixon sequences, and also diffusion is very helpful because usually there is the question of what is the pathology, is there a sign of inflammation, and we will not give contrast media unless it is absolutely necessary. So the problem of imaging in pregnancy is, of course, that there is the growing uterus, and in the 20th week it reaches the umbilicus. In the 36th week it reaches to the upper abdomen, and this will result in displacement of the ovaries and compression of the ovaries and the appendix, and also compression and displacement of the upper abdominal organs. And this is why sonography may be limited, and the more advanced the pregnancy is, the more limited is sonography. Furthermore, nausea during pregnancy is normal, and in pregnancy, physiological leukocytosis is seen. So this cannot be used as sign of inflammation, and there is also constipation and delayed bowel transit in pregnancy. Furthermore, we should know that physiological hydronephrosis is a normal finding in pregnancy. It's typically found in the second and third trimester, and that resolves after the delivery. And physiologic hydronephrosis typically is found on the right side and is classically asymptomatic. So what is normal? In sonography, the ureter is usually less than 1 centimeter. The distension is to the level of the pelvic brim. And in sonography, you will see a ureteral jet. So these are all normal findings. So here you see an example of physiological hydronephrosis, here seen on the right side. But this hydronephrosis is due to compression or hormonal dilatation. So this predisposes to pyelonephritis. And we know that pyelonephritis is more frequent during pregnancy. And if there is a need for imaging, then diffusion-weighted imaging is really helpful because it will nicely show these areas and we do not contrast. And actually, if this is the question, we do not need another sequence. Here I have summarized several causes of acute abdominal pain taken from this literature, and they differentiate between surgical causes that include acute appendicitis, cholecystitis, bowel obstruction, ovarian cysts, but here they also include renal colic and pancreatitis. We should also not forget the medical cases like constipation, urinary tract infection, pyelonephritis, gastroesophageal reflux disease, and pelvic inflammatory disease. And what I will now do is show you a couple of cases. And this is patient 34th week. The question is it appendicitis? In sonography, the appendix was not seen. So in sonography, if we have a pregnant patient, do not see the appendix, we cannot exclude appendicitis. She had pain on her right side, but here MRI is helpful. First, to exclude that this is appendicitis, this is the appendix. On the diffusion-weighted imaging, we would see the inflamed appendix. So this can be excluded. We can also exclude pyelonephritis. It could also cause pain on the right side. But what's the cause? And in this case, what we saw that she did have leiomyomas. They were high in signal in the center, so these were degenerated leiomyomas. They did not bleed because on T1 it had not high signal. And as I said, that's a quite common cause because the problem is that these leiomyomas outgrow their size, the vasculature, and this is then they get degenerated, and this causes pain. The important why we did MRI was to rule out acute appendicitis. And actually, appendicitis is quite common in surgery. It is most common in the second trimester, but perforation occurs in the third. As I said, leukocytosis is not reliable, and the problem of sonography is that the farther advanced the pregnancy, the less reliable sonography is. Here I have cases in the out of the literature where you see a normal appendix, and here clearly dilated, inflamed appendix, and here no other imaging would be necessary. But the role of MRI is when these sonographical findings are indeterminate or negative, to rule out these, and the imaging findings are those that we use also for CT or for not pregnant patients. And the benefit of MRI is no radiation, and the other benefit is the really high, excellent negative predictive value. So this is appendicitis. Another case of a patient with acute abdomen. She was 15 weeks pregnant, had a history of bariatric surgery 3 years ago. And when you hear this, you should always think of one diagnosis. And you see here the early pregnancy, and there are clearly dilated loops. There are fluid levels. On these coronals, we can see that this is quite high. This is duodenum, this is jejunum, and there are some bowel loops that are small in caliber, so there is an obstruction. And of course, as she did have bariatric surgery, this was due to an internal hernia, and she did undergo surgery, but unfortunately, she had already bowel necrosis. Another case, 25 years. She had emergency surgery outside of our institution because she presented with bowel obstruction. And at surgery, a tumor was found. It was this ileocolic tumor. Afterwards, we performed this MRI. We see that there is a mass. It's intermediate on the T2. Here on the T2, you see it also. This is T2 fat set. So this is clearly a mass. Doesn't look benign. She did have a biopsy, and it was non-Hodgkin lymphoma. And the consequence was that she did undergo chemotherapy, and her baby survived this quite well. So what should we know about acute intestinal obstruction in pregnancy? Actually, it's quite rare, but it's an important indication for surgical intervention, and it's really associated with a high risk for loss of the mother and the fetus. These are the indications. The etiologies, they do not differ from non-pregnant women, and tumors are, of course, very, very rare. And regarding the imaging modality, MRI or alternatively CT should be performed complementary to CT. And now this is the last case I want to show you and share with you. She is 36 years old, in her third trimester, and she presented with a hypovolemic shock and had always had upper abdominal or epigastrical pain. And she was really, because of this hypovolemic shock, we wouldn't do MRI, but we went for CT. And in CT, there was this mass seen in the area of the pancreatic tail. And here CT was performed, where we can identify clearly an aneurysm of the splenic artery, and this is ruptured. This is the baby. She did undergo emergency cesarean section, and this is an image of the open surgery with the repair of her aneurysm. And do remember that there is an increased risk of splenic artery rupture in pregnancy, and this is particularly true in the third trimester. And if you look in the literature, I think 65% of all these ruptures occur during pregnancy. So do think of it, particularly if the patient is presenting with acute upper abdominal pain. So my take-home messages are: ultrasonography is the first-line imaging modality for gynecological emergencies, both in fertile age and also during pregnancy. MRI is the second-line imaging technique in gynecological causes, but do not forget, if there is a question of GI cause or vascular emergencies or renal calculi, forget MRI to CT. And in pregnancy, MRI is the second-line imaging modality, but when there is an indication, particularly if the patient is hypovolemic or in shock, do not miss time to make the diagnosis with MRI, but you really use CT. Okay, and with this, I want to thank you very much for your attention.